Welcome everybody to the Healthy Hip Dysplasia podcast. I'm so excited for many reasons about this discussion today. First of all, we're actually being able to do this face to face, which is amazing. But we are really going to be digging into some really intimate topics, really answering some of your really important questions. And I'm excited to bring to you Suzy Shutt.
Hello.
Women's Health Physio.
Yes.
It's really cool to have you with us today and talking about some of these topics, because I just feel like some of these topics are a bit taboo. It's not something that we can really bring up comfortably to practitioners. And I know from a lot of my one-to-one work that some of these issues are things that people got burning questions about, but just don't feel confident to ask. So we thought between us, if we bring all these questions to you, hopefully it'll open up some discussion and just be able to guide some of you in your consultations with other health professionals and with your physios, and just, be able to open up that conversation. So we're here to talk topic number one about pudendal neuralgia. Let's just open up that topic, your experience with women's health, how you know about pudendal neuralgia, and then we'll kind of start talking about how it relates to hips.
Okay, so obviously, like yourself, Laura, my background has mainly been within like musculoskeletal physiotherapy, and I think it's probably been about 10 years now. I went pretty much straight into that, and it's only really now since being more in primary care, working alongside in the GP surgeries, that I then became a lot more interested in women's health, because I was finding that I'm seeing now quite a broad range of pathologies that are coming through and conditions that are coming through. And I was getting a lot of women around particularly around menopause age, that had these really random joint pains. They couldn't really pinpoint it. They'd had every single test under the sun, and I'd be sitting there thinking, what do we do? Like, where do we go from here, sort of thing. We've been through physio, and so actually I then decided to look more initially into like menopause and women's health. So I focused more on that initially, and then more of late I've been focusing a bit more on like postnatal as well. So but yeah, I really enjoy it. I think in Norfolk in particular, there's not lots of it. I know there's certain areas it's becoming perhaps a little bit more popular, since there's been a lot more sort of push for menopause training and things like that with different health professionals. But I think as well, then, from speaking to colleagues that also work in primary care, is there's a lot that we just don't know. And
agreed.
Yeah, and there's just so many. I think there's just so many women that still, I question now, there are so many women that get diagnosed with things like fibromyalgia or chronic fatigue syndrome, and I'm sitting there thinking, is it that, or is it actually menopause? And because when we look into menopause and women's health and all of the problems that can come with it, it's huge. There's such a scope. So that was why I then got into women's health. Cut a long story short, that's how I got into women's health. And so now I still do musculoskeletal like yourself, but I focus a little bit more. I prefer to do like women's health because I just have much more of an interest in it. And when you mentioned about pudendal neuralgia, it's definitely something that, from chatting to colleagues, it's not widely talked about, but I think it depends where your practice is, depending on how much time you have, and it's just quite a complex condition. So it's not always explored, I don't think, so much within certain teams if the time you have is a bit less.
Yeah. So, I mean, I just want to be upfront with everybody and say that before I started working closely with people that had some of these hip surgeries, I had never even heard of pudendal neuralgia. So I want to just make anyone that's watching this feel a bit more comfortable if you've not heard of it, if you don't know what questions to ask, because I didn't know about it until I started working one-to-ones and heard about it, wanted to know a little bit more about it, because it's coming up more and more.
Yeah.
And I just think how many people are having symptoms and just not feeling confident to talk about it. So let's dig in.
Yeah.
What is pudendal neuralgia?
So pudendal neuralgia, it's a neuropathic condition that affects predominantly around the pelvic floor. So there basically are three different functions, and it serves different areas of the pelvic floor. You've got basically three different branches. One goes to clitoris, and if you're a male, it goes to your penis. You've got another branch that will go to your pelvic floor muscles, and then you have another branch that goes to your anus. So they all serve different functions. And so that's why they can present in a wide range of symptoms. So for some women, they might have, as I think we discussed earlier, they might have a little bit of numbness around the clitoris. You might have other women that get severe pain with sex intercourse around their pelvic floor. And the same as well, I suppose, around your anus, if you have any loss of sensation around there, it can present anywhere pretty much around that area. So yeah, it's a neuropathic condition, and it will typically present with a few symptoms. So like when we screen, we check for sharp shooting pains, tingling, numbness, all of those types of, I suppose, clinical presentation really. So yeah, so that's effectively, trying to summarize quite a complex thing. That is what pudendal neuralgia is. It's
in summary.
Exactly.
So I mean, if I was asking this with absolutely no knowledge at all, I'd be like, okay, well, where does it come from? What causes it? And I'll talk a little bit about hip stuff in a moment, but because this is going to cross over with other conditions, and there are people that are going to be having hip surgeries that have been through menopause or going through menopause or perimenopause or have had children and having other kind of pelvic floor women's health type issues. So I just want to briefly cover other reasons that you can get pudendal neuralgia other than the hip stuff that we're going to talk about in a second.
Yes, yeah. So obviously, it basically comes from the pudendal nerve, comes from the real lower part of the back. So it's from S2, S3, S4. And for anyone that doesn't know your anatomy, it's basically the real lower part surrounding your sacrum, as Laura's showed there. So it arises from that level, and basically, like I say, it goes up into 3 different branches, so it's different parts to the pelvic floor. Now, there's lots of things that can cause problems with it. It's typically known to be a problem with cyclists because that's sitting.
Oh my God.
So, and it could just be a little bit of a temporary irritation, but obviously we're thinking more for like the longer term, aren't we? The people that end up having it for a bit longer.
But that is a really good comparison to make, because if there are only people that like to cycle, and I know there's a big part of the hip community that does, because it's a non-impact sport, so there's a lot of us that are cyclists. That feeling, that temporary numbness, that kind of ischemic kind of feeling that you can have, I suppose, is something perhaps to relate it to.
Yeah, definitely. And I think as well, like I suppose the ones we want, I don't see necessarily the people that you see, because we're slightly different in our practice, but yeah, that's one of the common things that it can be associated with. But I suppose like any nerve condition that we see, even if it's musculoskeletal, the things that can irritate nerve are I suppose if you have any compression around the nerve. So that can be from position. So for example, repeated squats, or somebody is in a deep seated position for a while, even that can sometimes trigger it. I suppose from my side, which I tend to see a little bit more of, is postnatal, because obviously that second stage of labour, as the compression and obviously the trauma that can happen around there, that can cause it. Trauma again is another area that can affect it, it's another reason. And obviously surgery, which is probably where your patients probably might come a little bit more in, maybe. And obviously any dysfunction to the hip pelvis, and actually from researching a little bit more into it, there's a lot about biomechanics, and actually with these types of patients, not just looking at the symptoms they get, but what's the cause. Like that's the main thing. It's
exactly.
like that's the cause as to why.
Yeah. Okay, so in terms of like the hip stuff, when we're talking about why do people with hip dysplasia get pudendal neuralgia, so obviously spent a lot more time over the last couple of years looking into this a little bit more, and it's really more to do with the hip arthroscopies that are happening, more than the PAOs or the hip replacements that are happening, and there's a reason for that. So when you have an arthroscopy, so this might be for if you've got cartilage issues, you've got a torn labrum, you've got femoral acetabular impingement. When they put you on the table to do it, they have to create some traction between the ball and the socket to be able to create the room to get in there to do the work they need to do. So when they put you on the table, there is this thing called a perineal post. Again, didn't even know that existed. I haven't had an arthroscopy myself. I've had the PAO, but I haven't had an arthroscopy. So I didn't have that personal experience. But you look into it and there's this big bolster thing, not this big, and they pop it between your legs, and they basically put your foot in a boot and then traction to be able to create that distance between the ball and the socket. Now when they do that, obviously that's putting a lot of pressure in your groin to the post that's being put there, and obviously it's a for a long period of time that compression is there for. And sometimes they have to put quite a bit of traction on to be able to get that pull from the ball in the socket. So there's research that we'll go into talking about a little bit further down the line, but why I wanted to make sure that people were aware that it's that surgery in particular is so that we can open up that conversation with our consultants, with our physios, to know that it's even a risk. Okay, so it's not a really common thing. I want to stress that's really important. And some of the stats and stuff from the research that I've been reading says that it happens in 1.8 to 4.3, varying on which study you read, of people that are having pudendal issues afterwards. So whilst that doesn't seem like a huge amount, if it's you that it's affecting, it's going to feel pretty significant. I want to stress that all the research that I've read about pudendal neuralgia with after hip arthroscopies, it's all gone within 6 to 12 weeks. So that is super good to know. I haven't found any cases at the moment, and you might say differently, that have gone on for longer than 12 weeks after hip arthroscopy. So that's a very small specific subgroup. Now, there are other issues like we've talked about with your women's health in your practice that will probably go on for significantly longer than that. So if you are coming at this from a point of view where you've had your surgeries and you've perhaps had a child and you're potentially in menopause and there's all these other things potentially going on at the same time, you could potentially have continuation, but it might not necessarily be the same thing that's causing it, right? There's so many different things that could be coming into play. So just wanted to kind of reassure you that if it's just from that perspective, I haven't found any evidence that it should carry on for longer than 12 weeks. So we can reduce our panic and anxiety perhaps just a little bit. So we just mentioned a few other things that might be drawn into pudendal neuralgia, lots of different reasons so far, but that's coming from my perspective, and I want to just invite you into that question. Is there anything else that you think might be a factor to consider?
Definitely. So other things that can draw into it. So we mentioned briefly a little bit about menopause, and obviously that's a huge subject. That's we could talk about that, or I could talk about that.
we might do another podcast about that, another topic to come back about.
So but obviously menopause in itself, so just sort of really briefly, when your estrogen levels drop, your inflammatory markers will increase. So it's quite common for particularly the women that we see in clinic that their symptoms might go on a little bit longer. I don't know if there is any studies in particular that just focuses on women that have had hip arthroscopies around a certain age to see if that recovery time is a little bit longer. But if it is, I think the main thing is don't be alarmed, because like I say, there's other things that can feed into that. And yes, menopause being one of them. It's not just that. Obviously estrogen acts to help to lubricate your joints. So if that's lowered and you're not taking any hormone replacement therapy, you might find that actually your joints feel a little bit stiffer. They might take a little bit longer or need a little bit extra work. So I think that's where I think we were saying we're quite similar in our approach. Very holistic. We tend to look at like a really wide picture, sometimes probably too wide. But
for the amount of time we have,
exactly,
which is probably something that you're going to talk about in a second anyway.
And so I think that's where it's really important to just take into account, all those different factors that can have a part to play. And sleep, depression, anxiety, that can all ramp up the inflammatory system. So again, like I always ask about sleep, you probably do as well, how to sleep and what sort of things can you sort of control, but you might come at it then from a few different angles rather than just like getting moving and strengthening it.
Exactly, because in our job we might have 10 people come in with the same symptoms, right? But we would treat them completely differently based on who they are, what their lifestyle is, like their personality, like everything about them. So you can have so many people come in with the same thing and your plan would be very different. But that's, again, taking that holistic approach and looking at a person rather than a condition.
Definitely.
So all of those things are so important. But we did mention about sort of time and appointments, and I do kind of want to come into that a little bit, because these topics can be a little bit more taboo, and people don't necessarily feel as comfortable to talk about these things, unless you're asked directly, do we bring up all of these things about our internet areas if we're not entirely sure about what's going on, whether it's the right thing to bring up, whether it's appropriate to bring up, all of these questions and all of these hesitancies for advocating for our own health. So in our situation, like we would make a point of asking these things, but unfortunately, there's not always the time in certain situations, in certain clinical environments to go into all those details. So we want to advocate again for people to just be able to understand it a little bit more, be able to ask those questions in your appointments, and just feel like you can, advocate for yourself a little bit more. Because again, if you've got somebody, let's, take the NHS into consideration here, we don't have the time, unfortunately, to spend as much time, energy, money on everything that we want to. The resources just aren't there. And, it's not to say that the people that you're seeing, the clinicians that you're seeing aren't caring, that they don't want to know about all this stuff. But that's again where the advocacy comes in, because if you're aware of it and you ask, they will make the time for you. But if you don't ask, and they've got a list of hundreds of people to see in a day, they might not get around to asking those things. So I think it's important to have as much knowledge and awareness before you go to these appointments as you possibly can.
Definitely. And thinking about that, and as well, I do work in the NHS, and I get 20 minutes for my appointment. So like you say, and that's not just sitting and talking with somebody and I suppose doing the assessment as such. It's everything. It's your notes, it's your checking for imaging, it's calling people to talk about their imaging, it's if you need to speak to the GPs, it's all your tasks that come through. So it is a lot, it's a lot. And I know that definitely I can't be as holistic in my NHS practice in 20 minutes than I can obviously in half an hour privately, because you can just explore much more when you're private. So I think as well, the other thing you mentioned, like people don't always like to mention these things. And honestly, even in pelvic health assessments that I do with women, they come in, they know what we're there to talk about. So, but they still never talk about their sex life. I very rarely have women that will just come out with it. I normally have to sort of probe questions and say, so, how is sex? Do you get any pain in having sex? Some women are still, understandably, feel quite private, don't always want to talk about it. But I think that probably it's an important thing to talk about, because there are lots of things, that can be done to help with it.
Absolutely.
If they want to. So even with pelvic health, like musculoskeletal, it's not something that I would ask, to be honest. In musculoskeletal, there's other different questions that I might be more guided to. However, pelvic health, I tend to ask about it, but still, the amount of women that are shocked when you ask them that question, and I think that's probably partly why it doesn't get recognised as much, because people don't always think to talk about it.
So should we open it up? So questions about sex and pudendal neuralgia, right? So if you've had a surgery, any other of these issues that we talked about that might have caused you to have alterations in your intimate life, intimate areas, should we be having sex?
Well, I mean,
does it depend from person to person and on the cause?
That's a very open question.
I know.
So I suppose it's very dependent, isn't it, on the patient, and how I suppose you go through all things like irritability and how, because if it's loss of sensation, that might be a little bit easier to work with in a sense, on the psychological side, than somebody who gets really severe pain, because they're probably less likely, they're going to be wanting to perhaps avoid those certain things. Something as well to think about is like position. So we know with the pudendal nerve that if you're in a sitting or a flexed position, that it puts more compression through it, it can put more stress through it, and nerves don't like to be stretched and they don't like to be compressed. So it might be something really simple, saying, well, actually, have you tried a different position that may mean that you're not putting so much stress through that nerve? And also, using things like sex toys, and I suppose even just the sensory stimulation that you can get from that. And particularly if somebody has pain, within women's health, we have things like dilators, which can gradually help, I suppose, a really hypertonic, so a really tight pelvic floor muscle. They can help with that. So there are lots of different ways around it. I think it's just having those conversations, rather than sometimes we put things in the closet, we try and just ignore them, don't we? And we think, oh, if I don't do anything, it might just go away, it might just settle in time. If it doesn't, then these are conversations that in pelvic health we have a lot. We always ask about it. It's not uncommon for women to get these symptoms. Yeah, and you know, I think we'll chat a little bit more into like pelvic health and perhaps as to why, you know, sometimes these things aren't noticed, and that might just be also due to pelvic health professionals, physios, whether we know to question into it a bit more. So
exactly. Well, like I said, I didn't even know that it existed a couple of years ago. And you know, we both qualified quite some time ago. So you know, every practitioner has their own niche area, their own area of specialty and interest, and it's about sort of maybe having the time to be able to find one that is in the area that you want. But yeah, it's something, like I said, to open up the topic about, and just know that if you've got any questions after watching this and you have them and you want to send them through, then you're very, very welcome to do that. Okay, so we've talked about sex as a form of stimulation that can either potentially be useful or harmful, depending on whether we're over or understimulated as a result of the damage that's potentially happened. So there are surely other things that we can consider doing. Is there any other exercises, massage techniques, anything else that you can think of that might be useful for somebody who's struggling with pudendal neuralgia?
Definitely. So so I think the main thing is, again, it's drawing back to what they're presenting with. So I suppose with the pelvic floor, you can, and particularly when nerves are involved, you can have loss of sensation, you can have like hypersensitivity. So it's trying to work out which one it is. And also even the, you know, if somebody's getting pain, it depends as well what area. So if it's more around the clitoris, then you'll perhaps focus treatment a little bit around there. If it's more the pelvic floor muscles themselves, then you would do sort of like an internal assessment to try to work out whether the pelvic floor is what we call hypertonic. So whether those muscles have too much activity or too little, because we know the pudendal nerve has a motor function as well, which means it controls the muscles, it has a muscular function. And so that's where we would basically focus it on, depending on what our findings are from that. So if somebody has a hypertonic pelvic floor, as in too much activity through there, and they're hypersensitive, then I would probably focus maybe a little bit more on things like breathing techniques, trying to encourage relaxation. There is some work in hyperpressives. That the research,
what does that mean? Just to get everybody's
sorry. So yeah, so hyperpressives. I'm in my own little world. Hyperpressives it's a breathing technique that basically it's all about your diaphragm and how your pelvic floor moves within the abdominal cavity effectively. So
it's fascinating, isn't it? That you can actually connect the two and feel things happening in your pelvic floor.
Oh,
breath. It's amazing.
Have you tried it?
Very briefly, but I've not done any kind of significant training or practice in it. So yeah, please feel free to elaborate.
Yeah, so I mean, there is a whole host of training in itself around hyperpressives, and some physios prefer to use them more than others. I suppose it's like everything. Some people find them more effective. I keep quite an open mind with treatment, to be honest, and I will quite happily use it in practice. And I do find, so basically with hyperpressives, what it's drawing in on is just basically how all of your how your pelvic floor works with your diaphragm and works with all of, you know, I suppose all of those muscles. I think that also the muscles through the spine are partly involved. And it's how, when you breathe, how your pelvic floor lifts and lowers. And it's not an actual active contraction that we'd be doing when we think about doing our pelvic floor muscles. It's more actually just the natural lift and lower that you will get because of the pressure within your abdominal area. So that's something that I would go through with someone quite a bit in clinic, because as you can imagine, some people are like, what? I don't really understand that. And sometimes it takes a little bit of work. However, you can then sort of incorporate your relaxation, which we know is really important with any sort of pain, and particularly if you get any heightened pain for a long period of time. That's a whole another area of patients.
Sideline questions to throw in.
Yeah.
If somebody really struggles with stress or anxiety and they're constantly in like a fight-flight mode, can people hold their stress in their pelvic floor? Does that ever happen?
Yeah, I mean, I think we all hold tension in different ways.
That's what I'm curious about.
And I think it depends what that stress and anxiety is about. So, for example, if it stems back from when they might have been younger, and if there's been anything like sexual abuse, or, you know, even things like FGM, unfortunately it does still happen.
So just for everybody's benefit,
yes.
FGM?
female genital mutilation, and it's more common within certain cultures.
Yeah.
So we just have to be a little bit mindful of people's backgrounds, because if there is that in their background, it could be that they have more tension around that area just because of previous experience, I suppose. So yeah, that I suppose it can, but when you think about it.
Okay.
But I think we always think of like stress and anxiety, we tend to hold it around to our shoulders more, don't we, and to our necks.
I know a lot of people that hold it in their bum muscles.
Yeah,
a lot of people hold it in their bum muscles. So yeah, curious as to whether it's an area that people commonly hold their attention.
Yes, yeah. But yeah, so you know, I suppose it's looking at the cause of the pudendal neuralgia and whether it's coming from the soft tissues, whether it's coming from the position, for example, like compressive position, or if it's coming from the trauma, and then you guide your treatment really more on that. So you can use soft tissue techniques. There has been some more research, particularly this year actually, that's been coming out about nerve stimulation, pudendal nerve stimulation, which is really interesting to read about. And actually for pudendal neuralgia, I think it's shown to be quite effective. So we'll watch this space of how things develop. It's not something that I do at the moment, but who knows in time.
We'll see where we go as the research develops.
Exactly.
And becomes a little bit more mainstream.
Exactly. And yeah, I think it's it opens up another window for this group of patients, really, if you know it's sort of more common.
Yeah. So we've kind of talked about a lot of the stuff around it and treatments and what can make it better and worse, and I just kind of want to bring it back a little bit to some of the things that you can speak to your consultant about if you're going in for an arthroscopy, or you've kind of resonated with any of these conversations, or it's particularly something that you might be concerned about, or you know somebody else that's been through it and you don't want to go through it either. There are different research tactics out there at the moment that are not necessarily mainstream, but there's a lot of research around different ways that they're trying to reduce the compression from arthroscopies on that perineal post that sits between your legs. So I would just like to let people know that there's a couple of things out there. There's something called the pink pad, and it's basically a mat that goes on the table that you're in for surgery, and it increases the friction, which means that they can put a little bit of traction on your leg and be able to get that separation from the ball and the socket without having to have the post. So because you're more sticky to the table, so that you can get that traction without having to have that there. So that's something to consider, and ask whether your surgeon is currently using something like that, or whether they have any other of these other options. The next one is that on top of the perineal post, there are cushions that are designed to basically have a gap. So they will go into the groin, and then they will have a little gap through, like in bicycle seats, right, where they've got gaps to be able to reduce that pressure. Yeah. So there are cushions that are being used now to be able to reduce that compression. But again, it won't be with everybody, so ask your consultant. And then there is another tactic that they're using about just putting you in a Trendelenburg position when you're in. So Trendelenburg, I'm going to talk about it probably too much on my page, but when you're standing, you can't really see me here at the moment, but if you take my hip height here and you stand on one leg, and you don't have the right strength, do you hear that click? I did. And you don't manage to keep that level of your pelvis through that strength, instability, whatever the reason, that position there is called a Trendelenburg. So the research that I've been reading basically shows that if they are putting people in a Trendelenburg position to try and create that opening of the hip position, that if you put 15 degrees of Trendelenburg, it reduces the pressure on the perineal post by 46%.
Oh wow.
So you still have the post, but putting in that Trendelenburg position reduces the pressure. 46%, that's absolutely insane. 10 degrees is like 28% reduction, so it's still really significant. So yeah, just to open the conversation with your healthcare team about the possibilities of having those things done. So if you know you're having a label repair, and you're going in, you can ask, what's the situation? I'd rather reduce my chances of getting pudendal neuralgia if I can.
Definitely. And I think as well, if you do get it, and you know, you're finding that it's not settling, then do seek help. And you know, whether you send a question to Laura or myself, or if you can find a local pelvic health physio, I would definitely seek a little bit more support with it, because the longer it's left, the harder we know that these things are to improve. So yeah, I definitely say to think just a little bit outside of the box if it doesn't settle. Don't ignore it. Don't put it in the closet.
Yeah. So we have covered a lot of the stuff about pudendal neuralgia that we wanted you to, and the other topic that we wanted to cover is menopause. Now you've already touched on some really good stuff about that already, but I just wondered if we could pick your brains a little bit more about menopause. Okay.
Yeah.
So I am 36 now, and I had I was about to say 35. But yes, I have had a button now 36. So I had not really considered menopause in my life at the moment. I'm fortunate enough to have not had to consider it. However, on conversations with people, I'm starting to learn that actually there can be symptoms coming in from a lot younger than I expected. So it brings into question, what is menopause? What is perimenopause? What are we looking out for signs and symptoms that we might be then able to relate to some of the joint pain stuff that you talked about earlier?
Yeah, so I suppose in summary, so perimenopause can start from your mid-30s. So
hello.
But yeah, it's something that, you know, until I researched into it more, I definitely wouldn't have thought in my 30s that I could be at a point where I might start to get these perimenopause symptoms.
Yeah.
So it can start from your mid-30s. It can start earlier if you have like pelvic surgery such as hysterectomy, anything that, you know, obviously they remove your ovaries, that can, now that's classed what we call like a surgically induced menopause. But that should, if somebody goes through that, they should automatically be offered HRT and they go through the consultants. There's a little bit more of a structure. When you're mid-30s, you may not necessarily even think about it, let alone if you start to get symptoms, think, oh, it could be menopause.
Exactly.
You're still young, right? I mean, 50's the new 30, right? So I think, so I think that's important to know, is that it can start from your mid-30s. That's a normal age for it to start. Now, obviously, the average age for menopause itself is 51, I think they say. Yeah, that's the point when they say, yeah, most women will have gone through it. However, that doesn't mean...
Oh, so is that the start or the end?
Well, this is the thing. Menopause can be a continuum. It's not necessarily, oh, you get to 51 and then that's it. So you can get menopause. I always sort of them in two sections. You've got perimenopause, and then you've got postmenopause. Now, in perimenopause, your periods will be a bit irregular, and you'll start to get symptoms like you can get joint pains, you can get electric shock symptoms into your legs, you can get dry hair, dry skin, dry nails, brittle nails, brain fog, all these things that can come with menopause. You can get that in perimenopause. When you get to 50, well, they say 51 on average, that's the average age. I mean, that's not for everyone. Some people in their 40s, some people are later than that, but that's on average. So we'll work with that. But women can get symptoms for up to 8 years after, and you're classed as post-menopause when your periods have stopped. You haven't had a period.
That's the less than a year. Right.
Yeah. So if you haven't had a period for over 12 months, then you're classed as post-menopausal. Right. But women can still get all these symptoms, which is lovely. Let's just add that into the things that we're more likely to get and experience in life. So yeah, so you can get symptoms, I think on average they say about 8 years after. So it take you what, like 58, 59, something like that. However, you know, that's just a very small box. There are lots of people that don't fit that box. And some people do experience symptoms much longer after that. So yeah, so that's, I suppose, the scope for perimenopause, postmenopause, and what sort of age you might start to think about it, maybe.
Okay, thank you, because that definitely clears some stuff up for me that I was not aware of. So you mentioned HRT as part of a treatment for going through any stage of those symptoms, I would imagine, but at what stage do you think HRT could be beneficial when we're talking specifically about the joint pain stuff that we're talking about today? And is it beneficial, risks, benefits, that kind of question?
There's been a lot more research recently that's now coming out more with HRT, because there's been a lot more, I suppose, media and awareness about it, which is great. So we tend to find, so if you have, say, an average person, not someone with a hip pathology as well, but obviously that's going to then feed into it. So about 7 out of 10 women will get joint muscle pains.
That high?
Yeah. Yeah.
This is why I was so excited to have this conversation today. I'm learning so much.
Yeah, it's that amount of money. So this is why now when I sit in my musculoskeletal clinic and I've got 20 minutes, if I have somebody around an age that's menopausal and I'm looking through their history thinking they've had loads done and they've been through physio and nothing's working, I then question them on, well, are you menopausal? What are your periods like? And actually, when we then start talking into it, it might appear that actually, yes, they haven't had a period for quite a long time now. And their symptoms started randomly. And also, I think the thing with hormonal pain is that it doesn't really have a pattern. So like our musculoskeletal pain, we're like, oh, well, this hurts when you sit or this hurts when you stand. And there's, I suppose, that really clear presentation a lot of the time. Whereas with hormonal pain, it's very variable and there's no real trigger. It can sort of flare up, settle, flare up, settle. And so I think it's just trying to get that really clear questioning and history. But yes, HRT in itself, I have many times now when I'm working in doctor's surgeries and primary care, if that's something they haven't considered, I will have a bit of a discussion with them about HRT, because from researching into it, if I had a choice of taking it, I'd take it.
You would?
Yeah, definitely. Obviously, there's a lot
of a personal kind of
I would, and I think it's because the risks of taking HRT, obviously the biggest thing is like breast cancer. That's a big thing. And that all started from years ago, from something that came out in the media, and I think there's a lot of scaremongering around it, and it's definitely something we have to be aware of, but actually the research now that's coming out is showing that the risk is a lot less. So the biggest cause of the higher incidence of women with death in the UK is heart disease and dementia. They're one of the two biggest things. And actually the effect that hormones has on that, and it's quite significant. Like when you read into it, it just makes sense. You think, actually, that makes sense in science and physiology. So
I want to ask so many questions, and I'm sure that there's going to be some that are physio related. I'm sure there's going to be some that are more general, but yeah, you're sparking so many questions.
I know.
Perhaps we'll write down and maybe come back and address this another time. Yeah, sorry, I was
no. So yeah, so I think you've just got to weigh up the risks and benefits, and yeah, I would always then obviously chat to the doctors, get the patient to book in with the doctor and have a chat with them about it. And I've had some women that have started taking HRT and their joint pains have gone.
Wow.
And they're literally like, I feel like I'm a new woman, I feel like I'm 25 again. And maybe we could all do a little bit of it, but yeah, it can make that. And they've been through all these avenues, and it could be something as simple as that, effectively. So I think it's definitely worth questioning into it. And obviously, if you do have somebody who has had previous hip surgery or has a hip pathology that might restrict their movement and cause more stiffness, they will get more stiffness after menopause because their joints aren't as well lubricated. The estrogen will help to lubricate the joints.
So HRT has definite benefits when it comes to specifically talking about joint pain. That some of our audience might be considering. But it's always important for us to say you've got to be considered as an individual. You've got to weigh up the risks and benefits for you and your lifestyle, and always talk it through with your healthcare provider.
Definitely. Always seek help. If you're unsure, always seek help, because Dr. Google can come up with a whole host of things.
Oh, blimey. That's not going to do that. But yeah, so they're the kind of things that I definitely wanted to cover for menopause, and I know that there's lots of other questions. Oh, very quickly, there was one more that I just wanted to get you covered from somebody that came through on Instagram. Can the trauma or the surgery induce menopause?
So there's no research to suggest it.
Okay.
And it's not something that I have seen in clinic. Obviously, if it's pelvic surgery for like a hysterectomy or that would induce early menopause. But if you're talking hip surgery and arthroscopies, there isn't research showing any of that. And I suppose when you think about the science of menopause and hormones and how it all works, I wouldn't be able to really say, well, actually, maybe there's a small link there somewhere. Like, it's just trying to work out the science behind it, because research, we always need more research for lots of different things. That's how they find things out. But at the moment, there isn't anything. And it's not something that I regularly would see in clinic.
Cool. Thank you very much. So I hope this has been interesting for people to hear about. And again, hoping that it's sparking some questions that you might be able to continue to ask or to speak about with your healthcare professional team. But yeah, if you've got more stuff that you want to know, we're open to doing another follow-up podcast to answer those questions. So thank you very much for watching and listening, and thank you so much for your time today when you're chatting to us about this stuff.
You're welcome.